All right, well, welcome everyone to the Washington State Telehealth Collaborative. According to the clock, I'm all here at 9:31, maybe a little bit early for some of you. We wanted to, first of all, thank our hosts who came in and the folks at Providence Swedish.
It's a mouthful.
Yes, so maybe I'll turn it over to Kathleen to do a little bit of an introduction, and also her colleague who wants to talk.
Absolutely. So thank you, everyone. We appreciate you joining us here at our Providence St. Joseph's Health campus. Kim is one of our leadership teams. I'll let her introduce ourselves. We are happy to be able to host Swedish, and I was previously Swedish, now part of Providence St. Joseph's Health, and we are a 7-state region. I'm going to let you go into more of the details, but I'm happy to have you all here and excited to be able to share the day with you.
Yeah, so as Kathleen mentioned, I'm Kim Swafford. I'm the Group Vice President for our Telehealth Enterprise, really focusing on strategy and business development across the enterprise. As Kathleen mentioned, our footprint is 7 states. In our telehealth program, we're in 8 states in over 120 different facilities. We have core programs like telestroke, telehospice, tele-ICU, telepsychiatry, and we're expanding into other regional programs that we have in our ministries to around 50 different regional programs. As Kathleen mentioned, she was at Swedish, and what we've worked on this past year is bringing our teams together as one unified telehealth team, as opposed to Oregon doing their own thing and Swedish doing their own thing, but really looking at how do we collaborate across the enterprise together. And that also includes our physicians. So as you all know, being part of, different telehealth divisions, that, we're trying to take scarce resources and scale them across geographies. And so it made sense for us to start with our own programs internally and then look at how we can partner with others going forward. I'm going to stop there and see if there are any questions about what we're doing and where we've been.
So Kim, we often ask the host to maybe share one learning point, if we can put you on the spot, that maybe would benefit folks who are in telehealth. Or
well, I'll share a quote from Shireen Schlegel, who can't be here today, but there's something she always says as we're doing different programs, but she says if it were easy, it wouldn't be telehealth. So I think that that's something that folks think, oh, telehealth is easy. My son will say, well, it's just like FaceTime, Mom. What are you doing all day? Like, what's your job? And I don't think people understand the complexities of telehealth.
Great. Good. So I think what we'll do next is just do introductions. We'll start with introductions here in the room. Maybe we can start with our guest today, Jonathan. Introduce yourself.
Sure. Jonathan Seib, here actually on behalf of the National Council of State Boards of Nursing, whom we represent in Olympia, to talk about the Nurse Licensure Compact.
Great. Thanks for coming. And
Alexa Silver. I work with Jonathan and Patty for NCSB. I'm Patty Seib and this. So
the team there.
Exactly.
Stafford Strong with the Senate Healthcare Caucus. Senate Republicans, I work with the Healthcare Caucus.
Stephanie Cowan, Multicare.
Brody Tschenko with Columbia Health Solutions, Regents Blue Shield.
Hi, Sarah Orth with Seattle Children's.
I'm Ray Hamley. I'm with Labor and Industries, Payment Policy and Provider Outreach. And I'm joined by 2 of my colleagues today who will be talking about payment policy at Labor and Industries for telehealth.
I'm Nicole Groen. I'm the program manager for the collaborative, and I'm also on the telehealth team at UW Medicine.
John Scott, University of Washington.
Marissa Jones, Coordinated Care. Nice to see everyone in person.
Mm-hmm. I'm Melissa Johnson. I represent the Washington State Nurses Association.
Emily Stinson. I work for LNI.
Mary Country. I work with LNI.
Good morning, I'm Tammy Crow. I'm with the Department of Defense. I represent Washington, Oregon, Idaho, Montana, Wyoming, and the state of Alaska, working on issues that affect quality of life for military families. Hi, Lauren McDonald, Policy Director at the Washington State Hospital Association.
Kim White, representing optometry through Optometric Physicians of Washington.
Great, thanks. So next I want to go to folks who are joining on video. Let's start with Representative Riccelli.
Hi there, Representative Riccelli, 3rd District, Spokane.
Great, thanks for joining. Francis Guff. Dr. Guff, do you want to say hi?
Oh, no, I don't think Francis is joining.
Okay, all right. Somehow I see her showing up there. How about Chris Cable?
Yeah, hi, good morning. Chris Cable, Kaiser Permanente, Washington.
Dr. Cable, great to hear your voice. See you. Cara Towell.
Oh, hi, Cara Towell with the University of Washington Department of Psychiatry.
Thanks. Jeff Jones in Newport.
Jeff Jones, family physician, Newport, Washington, and assistant clinical dean for the University of Washington School of Medicine.
Have you on, Jeff, and just a plug for Jeff that he's going to be hosting our next collaborative meeting up in the northeastern corner of our state. I think it's probably the furthest away that all of us have traveled. So it's a beautiful place near Lake Pend Oreille. So looking forward to seeing you in person in a couple of weeks. So next, Hugh Ewert. Hugh, do you want to say hi? And is Hugh from?
He's at Children.
Seattle Children.
Still Children. Okay. All right. Leah Rosengaus. Leah, do you want to say hi? Leah works with me. So is my counterpart, Mike Kim. Chris Bandoli. Chris, if you want to say hi.
Yeah, hi, Chris Bandoli with Washington State Hospital Association.
Thanks, Chris, for joining. So next we have a bunch of phone numbers. So if you haven't introduced yourself and you're part of the collaborative, can you please unmute yourself and say hi?
Hi, I'm Lana Ziguri, and I'm having issues with my mic, so I'm calling in through a phone. I represent CHI Franciscan, our care transformation and virtual health services.
Thank you, Lana. Anyone else want to say hi?
This is Lori Wakushige from Legacy Health.
Hi, Lori.
Hi, Lori.
Hi.
So we have Senator Becker on the phone. Senator Becker, are you joining the call? I know we have you on the agenda. I hope you can join. Maybe we'll see if she needs some help. We can give her some assistance there. Anyone else?
Yeah, good morning. My name is Lieutenant Colonel Joshua Paul. I'm calling in from the Regional Health Command Pacific from Joint Base Lewis McChord.
Great to have you.
Welcome.
Good morning. My name's Major Megan Matters, and I'm calling on behalf of the Army Nurse Corps Chief's Office.
Good morning.
Good morning. This is Leah Rosengaus with UW Medicine.
Hi, Leah. Let's see here. Anyone else wants to say it? Maybe Micah Matthews. Is that you, Micah, who's joined?
Good morning. This is Micah Matthews with the Washington Medical Commission.
Thanks, Micah. This is it's good to have you joining today.
This is Colonel Robert McCoy, Medical Squadron Commander, McCord Clinic, Joint Base Lewis McChord.
Great to have a good representation from JBLM today. Anyone else want to say hi?
This is Cheryl Huchala from Primera Blue Cross.
Hi, Cheryl.
Hi.
Looks like Jody Kunkel also joined. Jody, you want to say hi and where are you from?
Unmute. Hi. Is that coming through this time?
Yeah, we can hear you.
We can hear you.
Oh, sorry. This is Jody Kunkel. I'm from Healthcare Authority.
Great. Thanks, Jody. Anyone else wants to say hi? Big group today. It's great.
And Denny Lorden is en route from the airport.
Okay. So Denny Lorden will be joining shortly here. All right. So I wanted to share my screen to so that everyone knows what we're going to be going over today. So this is our agenda. And so the next thing will be to review the minutes from June. And just to kind of tee up things, Senator Becker and Stafford will be up next, and then Nicole will talk about some of the other states' payment parity bills that passed. And we'll turn over to our colleagues from Steve and Associates with the nurse licensing compact. All right, so maybe what I'll do is pull up the minutes from last time, and we can review those. And folks who are on the collaborative, if you want to make any changes, this is a good time to do that.
And also, if you review the minutes in the next day or so and you see something that you didn't catch today, just feel free to email me, Nicole, and I'll make those edits.
And I think if you're in the room, you can review those as well. Yeah. So I wanted to thank again our colleagues from Confluence for hosting us. It was a very nice reception. We learned a lot about what's going on in Central Washington. And I apologize in advance that I have a very slow version of Microsoft Word. So that's why I can't scroll. Lori was really nice and talked to us about what's going down in Oregon with Tau. It's kind of our counterpart there. Just follow this up a little bit. So for those who have great vision. We talked a little bit about patient surveys and some of the Google Analytics. And then we're going to hear more about the subcommittees that are have met since last time, so stay tuned on that. And then just a plug for some of the federal legislation that's going on, the Connect for Health Act. I know there's been quite a bit of activity in Washington, D.C. on a number of other telehealth bills. And that was pretty much it. Any edits or changes to the minutes that folks want to add? All right. Do I have a motion to approve the minutes? Jody, do I have a second?
A second.
Okay. Kathleen, any discussion? All right, all in favor say aye.
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 Thank you. Any opposed? All right, and we'll take that was unanimously approved. So next, let's go on to the legislative update. There are two bills that Senator Becker and Stafford wanted to talk about. And maybe if we can start with the training bill. Stafford, do we have Senator Becker on the line? Does she have any problems? Senator Becker, do we have you on the line?
I did. She said, I just got an email from her assistant, said she made 15 or 20 minutes.
Okay.
You want to do something else and come back, or I can discuss it now.
Why don't we wait for her? And if it's okay, Nicole, would you mind going over what's going on around the United States with other, we'll stay on the theme of legislation.
Yeah.
So Nicole's put together what's going on around the United States on payment parity legislation, and you're just going to have to tell me which one it is.
Okay. Should be
This one right here.
what is that one? Maybe go back into the
Okay. Do you want to just start talking about it?
Sure.
And folks, I'll get it, and folks in the room have a version of it. If you want to email us, you can look at it and let me master of technology here.
I can also, if you guys don't mind just seeing my speaker notes, I can also just share my screen, if that would be easier. So basically, I did a little assessment of all the payment parity language that's either been proposed or passed. And in general, so I included states just to get an idea of what's out there that it failed. And I've included states that are the legislation is currently active. So in general, oh good, that's staying up to date. So in general, there's 16 states that have even talked about this. And they can be kind of categorized into 3 different interpretations of the language. You can interpret reimbursement as equal to in-person reimbursement, like exactly the same or similar. But there's also a few states that have language where it's a bit more flexible, and it could be interpreted for higher reimbursement, for lower reimbursement. What I want us to think about today is, with each of these phrases and the specific words involved, we should think about who benefits from this language and who's protected from this language. So the most common is an equivalent reimbursement, and it's usually tied with an in-person visit. There's 7 states that either have this language or have proposed it, and there's 2 kind of categories that fall under this bucket. There's a vague phrasing, which is on the basis of or equivalent to, and what that means in context is you're getting a telehealth visit, and the reimbursement is equivalent to or on the basis of, or on the same basis as an in-person visit of the same visit type. So it's treated as exactly the same. They also are tying reimbursement only to in-person equivalent services. So the language kind of limits it so that it's only to in-person services. So it's not, the language isn't flexible about provider to provider telehealth. It's more narrowly focused on telemedicine. So for example, there's Colorado, and any bolding or parentheses is me, that's added in. So Colorado, for example, they say it's that reimbursement is on the same basis as carrier, and it's reimbursing the provider for the provision of the same service through in-person consultation. So that's an example of the same basis language. Hawaii, on the other hand, has equivalent in their language, and they specify face-to-face contact. So you see that same parallel in those 2 states. Delaware is an example of exact language. So this is taking the case that the telemedicine visit, it should be reimbursed at the exact same rate as an in-person visit would be. And their language is sort of comically sparse. It's just this one.
It's a small state.
So whereas, other, I know that the bill we'll be discussing today is an entire bill dedicated just to parity. Delaware has a line, and I am curious what this means in terms of implementation, but wasn't able to pull that data or that information here today. And then there's Minnesota, which has the same, reimbursed at the same rate. And if you were wondering, well, is there really a difference? New York seemed to think that there should be or would be, and they included both just to cover their bases. However, that bill failed, so it did not pass. So on the other end of, or on one end of the spectrum, you can also have language that's flexible and could allow for higher reimbursement, so getting paid more than an in-person visit. There's only 3 states that have this language, and by have, I mean they've proposed it, not necessarily that it's been passed and implemented. And the only risk, the risk that at least became apparent to me is that by having language for a higher reimbursement, you may risk having some of that cost to be transferred to patients. So Arkansas, this is a lot of words, apologies. So they have the standard that, it's on the same basis. However, if on the second paragraph, they say that whatever you're reimbursing for, it shall not be less than the total amount. So it can't go under. They have specific language that it can't be reimbursed less for an in-person visit, but they don't have any language saying about a maximum. So I thought that was worth noting. Oh, yeah, sure. Oh, sorry, yeah.
Perfect.
Awesome, thank you. Okay, so you can read it. Oh wait, no we can't. Gosh darn it. Oh, I know what it is. Hang on just a second.
Standing it's in front of you. We're just trying to, so everyone can see it. There you go. Perfect.
So yeah, so Arkansas they have language about a minimum, but they don't have a language about a maximum. And that's kind of similar to what you see in Massachusetts as well. So the language is they're reimbursed at a rate, not less. They don't put a cap on it. They just say it can't be below whatever an in-person rate would be. And there is some flexibility there. I think that allows it to change as the market changes. But it is interesting what they chose to include and not include. And then New Mexico, very similar language. So on the other end of the spectrum, you have some states that allow for lower reimbursement, or actually, set a maximum and say, okay, this is as much as you can reimburse for, but anything less is more acceptable. But there is some variation. There's only 3 states that have this, and each one is kind of a little different. So Kentucky, for example, they sort of say that in a normal situation, the reimbursement should be equivalent, but there is an exception where if there's a contract between the provider and the payer, then it can be reimbursed for lower or for less than an in-person visit. That's the only exception.
And just a note that the bill in Washington State was pretty closely modeled off of Kentucky.
Right.
Is that right?
And in Oregon, they actually pull out specific percentages. So they don't have a maximum per se, but their baseline, their standard is below an equivalent. So it's an 80% of a reimbursement for healthcare generally, and then 90% reimbursement. Sorry, there's like very specific language there, but it's 80 and 90% depending on the type of service provided. So they start at a lower baseline, and then there's no maximum, so they could still go over, but in general it'll be less. And then New Jersey, so the next 2 states, and these are the last 2, so I'm sorry to throw so much information at you, but I wanted to highlight the next 2 states because they include specific language that doesn't allow any cost to be transferred directly to the patient for out-of-pocket costs. So they pull out deductible payment and coinsurance and essentially say that, if you're going to reimburse less, then the payer can't make up the difference by adding that cost to the out-of-pocket costs of the patient. New Jersey does this, and North Carolina attempted to pull similar language, but that bill did not pass. So I just wanted to highlight, I thought that was interesting, and it's interesting that there's only 2 states that do so. So we're going to be talking about Washington state policy today, and we're going to be analyzing it with Stafford and Senator Becker, hopefully, if she joins, or if she can join. But I just wanted to have us all think this is sort of the lay of the land. Most states are doing an equivalent. However, there are a few that are messing or trying out more or less, and they're significantly tied to in-person services. And how do we want our state to move forward?
It looks like there was another one that joined the ranks 2 days ago, Texas, and
oh really?
They use typical language that's also to the same extent. So I don't know if there's much impact on what that actual language is versus what is the reason ours didn't pass last time. Maybe Stafford has an idea. I think Senator Becker had an idea, was going to try and figure out how to do that. But I wonder if it's really focused on the language that's in this bill versus what might have took place behind the scenes.
Another question I had was, what does the on the basis mean? Some of these states that have used that basis language.
Right.
Maybe Stafford or some of the legislators can help us understand. Is that really saying like there's a negotiated rate? So I don't understand practically what that means when you're saying it's on the basis of
Is this from the other state's language or from our?
From other states, yeah.
I don't know what they mean by that.
Okay.
Yeah.
Our understanding of basis is just it's more that the methodologies used to calculate the fees are consistent across. You're not creating a separate methodology. It doesn't necessarily mean that the rates are the same, but that's
the same methodology.
Yeah, and so if you have a fixed conversion factor that you multiply by an RVU weight, that you're using that same methodology as opposed to creating some other methodology. And I think basis gives you the flexibility that the rates can be different, but you have to justify that your methodology is consistent.
Are we trying to understand this language and its potential impact and possibly change it based on what the impact is? In other words,
yeah, I'm just answering that particular question. I don't know what the purpose.
We're not clear on what the impact of this language might be. I'd be happy to do some research with some people in DC and find that out. But I'm more concerned about why this bill failed.
Part of the reason that we are using telehealth technology is to create new ways to access care, right? And new ways to deliver care. So my concern with using payment parity language is that we are limiting ourselves to the equal of in person. So we're not accounting for things that technology can do that are outside of the in-person consults, like remote monitoring. So that's completely left off the table.
Yeah, maybe I have a feeling that Senator Becker is trying to chime in here. Senator Becker, do we have you on the line?
Yes, you do. I'm on the line, and I just got in about that last part about a bill failed and parity. Are we talking about the parity bill that failed last year?
That's correct. Danny Lorden was asking, before we take a deep dive into, comparing Washington State's laws and with some of the other, he was just wondering, is it an issue with the language, or is there something else that maybe we need to be more aware of? So I don't know if you're able to say anything about that.
I am able to talk about it a bit from my perspective. As you know, I'm very pro getting some kind of a parity bill passed, but one that has some value. I've noticed a couple states have added, actually 3 more have added parity, but their language appears to be different. But as far as the bill last year, it failed, and I think it's an opportunity for us to look at it again and change it and write a new bill that we all feel is compatible. We did have Primera went neutral on it. Regents was okay with it when we talked about it. As it was written, we made some concessions that I'm not sure that everybody would agree with at this point in time. So I think it would be worthwhile to look at it. The current status of the bill is it's in rules, and we don't have to start entirely over with a brand new bill if you feel that the bill as written that I think Stafford provided for you is what you want. But I think it's an opportunity to take a look at it again and make changes, and we'll work with insurance companies and get it passed this year. We have to get it passed.
Great. So maybe if it's okay with you, Senator Becker, I've pulled up the Stryker Senate Bill 5385. And I'm just wondering, do you want to talk us through it? Are there any particular changes or key provisions that you want to talk to, you or Stafford?
Well, I can go first of all. I think that Medicaid managed care plans have to pay at the same rate. They already are. From my conversations with Judy, and I'm going to blank Dr. Judy, blank on her last name. Yeah. And one thing that we did do is in the bill last year is it permitted the hospitals and the hospital systems, telemedicine companies, and provider groups of 11 or more to negotiate and agree upon a telemedicine reimbursement rate that differs from the in-person rate. So that opened up a door for the larger groups. My fear is the smaller groups will have a take it or leave it. Like when I negotiated contracts with the small groups, it was a take it or leave it. So I want to make sure that we are all comfortable with the smaller groups, and we've addressed it. One thing that I thought was good is it required the reimbursement for the facility fees to be subject to the negotiated rate, which is basically the same thing as today, but it said it would set it in statute. You had the ability to negotiate the facility fee. It removed the requirement that services provided through store and forward technology have an associated office visit. I think there's room for discussion around that. And then it actually directed the telemedicine collaborative to study store and forward technology. In discussion with the insurance companies, they had a concern about the store forward technologies and the reimbursement and the payment of those. So I think that, I know Brody's probably on and others with insurance companies, and I think that would be a really wise move to open that discussion up, and then move forward with it.
Great, thank you. So maybe I've opened up for discussions, particularly from Brody, Cheryl, Chris, Cable. I don't know if this is on, but we'd love to hear the payer's perspective on this current iteration.
So I have two thoughts. I mean, first of all, we do cover store and forward, so it's not really an issue about coverage. I just think that the services that are provided through store and forward are different. I think Sarah's listing that as well. So to put that in like a reimbursement parity bill seems a little confusing to some extent, because like there is no in-person equivalent of monitoring, but yet if there's some payment parity language that we have to pay it the same as in person, is just confusing as to what that means. So I don't know whether the concerns here are more about coverage or more about reimbursement. And so that part has always kind of stood out as something that we couldn't quite reconcile what that meant. And so we're happy to talk about that more.
Is that for the store and forward part of it?
Yes.
And I'll just note that the parity language in this bill, store and forward is not included in that. It's just
study.
Yeah, they're to study store and forward, but when it refers to the parity language, it only talks about the telemedicine part.
I think there was some reference. I know there was language about removing that it's not associated with something. I'm fine. I'm not speaking on behalf of the other plans. I mean, we're fine with that removal. It doesn't have to be tied to that. But I still think there's some reference to store and forward in the parity section. I may be wrong. I just read it yesterday, but we can look into that. I mean, we don't need to confirm that.
And just to summarize, your concern is that not to mix store and forward payment with the more traditional direct to patient live video.
Right. I mean, I think they're for different purposes as well, right? So as long as it's clear that the store and forward isn't mixed in with the parity to in person, because we don't know what that is. Maybe that's why the basis, I'm not even supporting that, but maybe the basis aspect is why other states may have selected that term, because as long as you're consistent in your methodology. The other thought is just more of a observation or a question, and it relates to and maybe the 11 or more kind of addresses that as far as the group size piece, but I believe that there are many clinics out there that have a differential charge out to the public for telehealth versus in-person, and a lot of this language is about reimbursement from plans, but to the extent, like, I don't know whether other states have settled, well, does that mean that doctors can't charge a different amount? Because there's I mean, even if you go to the University of Washington virtual clinic site, the cost that's being presented for a virtual visit is actually around like $35 or something like that. And so there's just multiple facets to this that I'm not really sure what it really means as far as like reimbursement parity. And so to the extent, does this actually start to spread itself into the way that doctors set prices for things? And it's more of a question. It's not.
So Brody, this is Randy. When you're talking differentials, are you talking about the differentials defined by location? For example, King County gets paid more than Pierce County?
No, just if you go to many of the clinics, even represented in this collaborative, if you go to their specific website, you will see a price that is being shared with the public that says that a virtual clinic visit is like $35, $45. And I'm very confident that that is not the same price that if you went into urgent care or to a doctor's visit, it would not be $35 to $45. So there's a lot of focus on reimbursement, but my general question is, do these bills impact, the ability for what a clinic would charge, because they're charging differentially, but yet there's a bill that says we can't reimburse differentially. So to the extent that the general public who walks off the street that goes into a clinic pays $35 in cash, if that's the charge that comes to us, does that mean that we don't honor that price, or do we have to? So it's it's kind of like the next level down of, okay, once something passes, how do you implement these things? There's just a bunch of those questions. So it's kind of more of a question rather than a request. There's downstream impacts of these types of things.
So I guess the question, does this bill impact the self-pay or cash pay price as well as the insurance price?
I believe that I'm not the expert on this, but my understanding of the rules is that doctors can't differentially charge, like there's one charge, right? Mm-hmm. And so,
for that service.
Yeah, and so you can't, so even if your reimbursement is X, but you charge, most health plans have rules that say we pay the lesser of what the doctor has charged versus what the agreement is. And so does this impact the ability to do like basic processing?
And maybe I can clarify the difference between like what UW medicine doctors are doing and the virtual clinic which you're referring to. So that is something that is subbed out to a national telemedicine company that has a different cost structure and efficiency. And I think that a lot of us, the health systems are probably with the same provider, not the same, very similar kind of business model. And that's why. But we personally don't have any UW medicine doctors who are providing that virtual clinic service.
There may be other clinics that do staff it with their own doctors, though.
Yeah, we do.
Well, Brody, let me ask you a question. This is Senator Becker again. The question I would have is, back to you, a virtual visit like Teledoc or any of the other kinds of doctors, or if they're doing it within their own clinics, and they're charging a flat fee, that means that flat fee, if I am not mistaken, is not under the same guidelines as charging an office call of a 99213 or 4, because there's certain criteria you need to meet in each of those. So when you're talking about an office call of a telemedicine visit, and it actually encompasses the entire all the processes to meet the coding guidelines, and that's why we've been talking about fraud in the past. Meet the coding guidelines, that doctor should be able to charge for that office visit at the appropriate level. If you're using a teledoc or a clinic is setting up a virtual visit and they're offering it at a rate of $35 or $40, a couple concerns that I would have there is, are you then, if they're sending the bill into you, are you applying it to deductibles and copays, et cetera, to that, because you're charging it out appropriately? I don't want the patient to get caught in the mess of they're paying for a visit and paying for insurance, but nothing is going to their deductibles.
Yeah, I think that's probably different than the point that I'm trying to make. But to answer your question, if the doctor is in network, the claim gets processed as if it was covered. So if they had a no deductible plan with a $10 copay, then we would treat that as such. And so we aren't treating in-network doctors differently by picking one set of benefits for one and one set of benefits for another. So my question is just more that do these reimbursement bills impact clinics' abilities to differentially set pricing as opposed to the coverage of it? Because I'm very confident that when claims get submitted, they get processed correctly. So.
Could, in the interest of time, Stafford, would be okay if we go to the other bill?
Yeah.
Okay. Good, so I'm going to pull that one up. With regards to training, so Senator Becker and Stafford, if you want to speak to the other bill on training, we go through that. And this is Senate Bill 5389. Senator Becker, yeah, this is about a treatment program to assist youth.
I would love to talk about this one. This bill did not pass, as you all know, but I have to tell everybody in the collaborative, I really appreciated everybody coming and testifying last year. It really helped. It shared the insight and the work that the committee had done, and I think that's why we had some of the successes that we did. But this bill, 5389, made it through the Senate. And it was really fun. I worked with I've never worked so hard on a bill. OSPI was in favor of it, and multiple people in favor of it. And it got over, they referred it to, instead of the healthcare committee, they referred it to education. And the education committee, of course, knew nothing about telemedicine. And so in the gal, Representative Ortiz is her last name, wrote some amendments to the bill that actually would have really hurt our telemedicine work that we've done already. And so the bill itself died, and I think needed to die, but we were able to get it through another way. And what we did is we got it through the budgeting process. So we created a budget proviso, and it allowed for the bill to move forward as it almost as written. But basically what it did is it said there were going to be 2 school districts that would enter into a pilot program. The University of Washington has their first year to develop the training program, and they're in the process of doing that, my understanding. And then the second year of it will be to implement the training in those 2 school districts. And we wanted 1 big district and 1 small district. And so that is moving forward. So what we need to do is rewrite the bill for this coming year, and write it in a way so that hopefully it gets referred to the healthcare committee where they understand all of the work that's gone into telemedicine. But I'm really tickled. Christine Rolfes, when I went over and told her that the bill was dead, she said it was such a good bill, Randy, let's get it in the budget. So Christine Rolfes, Chair of Ways and Means Committee, really helped to get that done, and she deserves a big thank you. So that's where we are on that bill today. And I hope I covered everything, Stafford.
Yeah, and just a summary of the bill briefly. It provides training for school staff and junior high, middle, and high school students to identify students who are at risk of suicide or substance abuse and mental health issues. And then it allows or mandates that schools provide a room and a location for students to get a telemedicine psychiatry visit while at school during school hours. And then if a second one is recommended, then a second one will be set up with a psychiatrist, and it doesn't go beyond 2, but it can be recommended out after that. It's a way to get telemedicine and mental health services into the schools, and it also requires that all staff be trained, not just teachers, so bus drivers and nurses and those that see the students that might recognize that they're acting off. It allows them to train them to identify these students and to get them help if they need it.
Really important bill. Cara Tal, this is kind of in your area of expertise. Anything you wanted to add about this bill and whether this is something that we could support?
Yeah, and to be honest, I'm not very intimately involved with this because it's more of a children's hospital. So Sarah may actually know more about it than I do at this point. She's smiling. I don't know if she knows me.
I've heard a lot about it, but I'm not comfortable speaking to our position at this time.
Yeah.
So, and just from the University of Washington perspective, I'm happy to support it and provide the technology and infrastructure to make sure this happens.
I'm a Swedish hospital provides telehealth services to the Issaquah School District and has a program set up over the last 3 years. I would say Stacia is intimately, she's our behavioral health clinical program manager. PSJA initiated the program at the Issaquah School District. So if I share any information that we have from that, I'd be happy to.
That'd be great. I just want to make sure everyone heard what Kathleen was saying. And she said that Swedish has a relationship with the Issaquah School District to provide psychiatry services there.
It's social work okay. Support within the school districts. I believe it's at the 2 of the major high schools and at a couple of the middle schools, but I'd have to verify that information.
And my recollection is that Kaiser also has school nurses, at least in Seattle Public Schools. Chris, do you know anything about telemedicine and in particular telepsychiatry in the schools through Kaiser?
Mainly right now we're offering it in terms of video visits, and we do those both internally, and we also contract with an external vendor, Ginger.io, we're now called Ginger. So that's the main vehicle for us at the moment. We actually are looking at some health and wellness and online CBT therapy as well. That's present in some other KP regions, and we're thinking about bringing that into Washington within the next year.
That's great. Do you have like a one-page flyer describing that program that maybe we could share on the collaborative website?
The CBT and online health and wellness tools?
Yeah.
It's a little premature because we haven't brought it in here yet fully, but I can have that be done as soon as we do that. I can check with our mental health and wellness teams on when that's anticipated to arrive. It might be by year end.
Okay, maybe we'll check in with you about that. Just as one of the functions of the collaborative is to be a forum and make sure that we're sharing all the expertise around the state. So it'll be good to know how school districts can take advantage of the services.
Dr.
Senator
Scott?
Becker.
The one thing that I would like to say is I'm glad that there's so much going on and not waiting for us in the legislative body to make anything one way or the other. But there are a lot of issues still around mental health in school, and I'll use Bethel School District. It's the 13th largest school district in the state, and there are no doctors hardly at all in the area. We have the second lowest number of doctors in my district, and that's just MDs. That's not talking about the mental health doctors or providers. And so while we can still get, through this, with this program, 2 visits, maybe it's the counselor at school has the initial consultation with the UW, and then the student has a consultation if deemed necessary. But the problem still is going to be referring out to a mental health provider so that a family can get to them. And when we're looking at some of the free and reduced lunch numbers, these people cannot get out there to get the care they need. So we need to really have this bill move forward next year. Well, we have a good start on it with the proviso. We need it to move forward, but we still need to consider how we can incorporate the providers that are not at an PhD level, MD level, that they have the training so that we're getting consistent. Because Issaquah may be setting up a program that does certain things, and Cedro Woolley another one, and we need some consistency so we can actually make sure that what we're providing to those students will do some good.
Dr. Scott, if I could add a comment.
Representative Riccelli wanted to say something, and just so folks know, Representative Riccelli during his day job is an expert in this area. This is kind of what he does when he's not in Olympia. So Representative Riccelli, I'm sure you have lots of thoughts on this.
Yeah, no, particularly Senator Becker. I'd like to talk offline. I think a good resource too, as far as just the place part of this, like where these telehealth appointments going to happen in schools. There's a lot of movement, as you know, and I think Bethel is bringing online a school-based health center. Is their advocacy arm is growing, and just working with the School-Based Health Center Alliance, the Washington State, I think it's the Washington State Health Alliance, to get them engaged and interested, because I think that they're a great resource, and just really plugging in the school-based health centers as we grow those. So I'd love to chat with you about that, because I think that's a natural ally. Yeah, thanks.
Have we identified the 2 locations where this would be piloted?
Senator Becker of Stafford, and the question is, have we identified the two school districts? I know one was going to be urban, one was going to be rural. Okay. Do you guys know?
No, actually, I don't. And I don't know if Stafford does, but I know that I was advocating for Bethel as one of the rural, simply because the Department of Health in Pierce County did a survey of the students, and the superintendent said it is absolutely awful, the numbers of the students that have indicated they've thought of suicide and doing drugs and all that. So I know that I'm trying to look at an area that services aren't so readily available, that can show that this will really work.
Bethel's the one that I've heard, though I haven't gotten confirmation.
I was just throwing that out. We were doing some research the other day into psychiatric triage, and looking at Stevens County had the 2nd highest success rate of suicide in the state.
Yeah.
Lewis County.
Stevens County. Colville, Julia area. I wonder if it makes sense to target a high vulnerable population.
Right. Denny, I surely hope we do, because that would actually be a positive for the kids there, but it'd be a positive for this program too.
Sure. So I wanted to go to Marissa and then Hugh. Marissa?
Okay. I have a feeling Hugh's comment might be similar to mine, because we just saw one another in Olympia at the Children's Mental Health Work Group. They're also very interested in getting more resources into schools. This is the group that Representative Frame co-chairs with Healthcare Authority, Marianne Lindeblad. There's a lot of folks around the table at that, including OSPI, and they're wanting to tee up their priorities sooner rather than later for next session. So this could be a good alignment opportunity with that group.
Do you suggest maybe inviting that group to maybe speak for the collaborative?
Or seeing if there's time on their next agenda to talk about the bill.
Great.
Yeah, and I worked with Representative Frame. The one difference is, and this is what the Office of the Superintendent of Public Schools said, is that there's a lot of people out there trying to set up training and programs within the schools, but there's nothing that's providing the treatment. And that was what made this bill so different and unique. So legislatively anyway, so.
Great. Hugh, you were from Seattle Children's. I know you wanted to chime in.
Yeah, thank you. Hopefully the audio finally works. I did try to say hello initially, but my computer mic didn't work. Yeah, I just wanted to chime in that we were involved in the development and kind of modification of the budget proviso language around the telehealth program for youth, and so are very supportive and are working closely with the UW Ames Center or Smart Center, pardon me, to identify, and of course with OSPI as well, to identify which school districts will be a part of this and how to roll it out and what the curriculum will look like. And so absolutely on board and a part of it. And I think, you know, the challenge will be, and I completely hear what you're saying, Senator Becker, about the uniqueness of this approach, including treatment, will be to ensure that we have the workforce to provide the services that are needed. There's as you all know, there's a woefully inadequate workforce across all levels around behavioral health. So we need to work on that piece together to make sure that we can provide services to kids in schools or remotely from a school-based setting. So looking forward to working with you. And to Marissa's comment, absolutely, there's a lot of intersectionality between the Children's Mental Health Work Group that's underway and the work that you all are doing. And I think closer synergies between the two groups would be very, very helpful as we head into the session.
So maybe as an action item, if I can ask you and Marissa to make an introduction to myself, maybe Sarah, and obviously Senator Becker and Representative Riccelli, to see if there's some way to have a sharing of information on that.
Sounds great.
Any other action items from this? And I hear concern about what happens after those first two visits. And I think overall care, that's a big issue in psychiatry in general. Okay.
Well, this is Senator Becker, and I have just to pop in here because this has been so near and dear to my heart. But I do have really big concerns about the next step if they need to be if a child needs to be referred out to a provider, and I'm looking in a lot of the areas where we don't have enough providers. I totally agree, and I think that we might be able to work through Project ECHO and do some additional training to the people that are out there, so that the ultimate goal would be to have them reporting into AIMS or SMART or whatever it may be that we decide, but so that we can see if the treatments that providers are providing is actually doing something. The thing that always resonated with me is when Dr. Unitzer said, we do a good job of making good patients, but we don't do a good job of making patients well. And that has to be the goal of this, is how do we make them better, not well, necessarily. And so that's been my concern. That's the second part of this.
I do want to make a plug for a new Project ECHO that was funded by the legislature last year that may be relevant. Is there's an autism ECHO that will be starting in December. Dr. Gary Stobie will be leading that. So if anyone in your organization is an expert or has a lot of patients with autism, you can join this for free. It's for adults and children. Gary is an adult neurologist and has expertise on that. So kind of touches at some of the issues and as I said, free and gets anything. Okay, was it okay to move on to the next agenda item?
Yeah, well, just one more comment. If you guys do read through these bills, the printouts that are here are the latest versions of the bill. You'll see it's a striking amendment. That's because the dates are updated. If you do have recommendations or changes, I would encourage you to send those. You can send them to me, I would assume. That's okay, Senator Becker. And then we can get started on it a little bit earlier rather than right before session.
Do you have a time frame that you need comments back for either of these?
We're still early. Just in the next month. I mean,
okay.
I wouldn't wait till November. That's too late. So.
And if you recall the meetings last year, we talked about the timeframes in order to get it pre-filed, et cetera, so that we're in early. If we could have a bill written by the end of November to have it ready to drop, that would make me comfortable, because then we would have agreement with you all and we could move forward working with the other people that we need to work with.
So if we do make some language changes, do we need to bring that back to the group, or are we going to move forward with it, or what's the plan?
I'd just say send that to Senator Becker and Stafford and Representative Riccelli.
I assume changes, recommendations before next meeting would be beneficial, because then we could discuss them here.
This meeting is only about a month away. That's just the way it's
We'll do that, and so send it to those three people, and then myself as well. We can do the suggested changes. Okay. Great. All right, so let's move on to the next agenda item, and that's to talk about the Interstate Nursing License Compact. And I'm going to turn it over to Jonathan, Patricia, and Ashley to talk about that.
And it's actually, there's a correction, it's Alexa. Alexa's over. And I actually think we're going to kick it off with Representative Riccelli who I think actually is responsible for having this before you on the agenda, and is going to be the lead on it in the legislature. So I think you want to say a few words before we jumped into more of the details about what the bill does and a little bit more background.
Great. So Representative Richelli.
Sure, yeah. Yeah, thanks. I'll be really brief because I know we're crunched for time and I want folks to hear from the people that are in the room. And it's great to have so many of our members of our military involved in this meeting today. So I just want to give a little background. I also ran the medical licensure compact a few years ago, so I became kind of aware of the benefits of the compact agreement and the interstate efforts. But I came to it as, kind of a three-legged stool. And first and foremost, my community has really asked on behalf of our military families that we look at, we have Fairchild Air Force Base in the area and a committee called Forward Fairchild, and our Greater Spokane Incorporated, which is our Chamber of Commerce and Economic Development entity, has prioritized this. And so, I spent the last bit just hearing from them and the importance of that, and military spouses and what it means to come to a community and be able to work quickly and get engaged, which I certainly support, and I know a number of folks in our community and members support. I also think from an emergency preparedness standpoint, if God forbid, some sort of disaster occurs, we want people to flood this area to help out, but we want to make sure that they're have the proper credentials. And then finally, obviously, the telehealth piece is something that is near and dear to all of us, and something that I look at and how we can benefit from being part of this compact, and from a workforce standpoint to look at. And I just want to be really clear because there seems to be some confusion. In the bill, nothing will affect the requirements established by a party state for the issue of a single state license. This is an option. I just want to be really clear for everybody in the room who's following this. This is just an option. There's no mandatory requirement. There was some thoughts going around and maybe some miscommunications that the Nursing Commission was going to move to this solely. That is not the case, and I'm very pleased that that's language in the bill. So I'll leave it there and just say thank you guys for putting this on the agenda. I will be prime sponsoring this bill. There were a couple of good amendments that they can talk about that were made in the bill that was sponsored last year, and I look forward to the discussion on this topic.
Great. Thanks, Representative Richelli. I imagine the other issue is you, being in Spokane, you have a number of families that maybe live over the border in Idaho and sometimes wanting to go back and forth, kind of similar to Vancouver and Lori Wakashi's experience. Does that come up?
Absolutely.
Yeah. Great. So maybe
absolutely, being a border community, yeah.
Yeah. Maybe we'll turn it over to Jonathan.
So I will start walking through our slides, and again, be conscientious of your time.
Is it this if you want to do?
No, I think you should have a PowerPoint.
Once you start,
okay. So I will just start, and just want to give you, like I say, we are here really on behalf of the National Council of State Boards of Nursing, which we label the keeper of the compact. They really are a much more comprehensive organization, an organization made up of the state nursing licensing boards of the 50 states. I believe there's some territories as well. Our state Nursing Care Quality Assurance Commission is a member. In fact, I think you would have Paula Meyer, who's the executive director of our state commission here today. But it so happened that this coincided with the national meeting of the National Council of State Boards of Nursing. So Paula is there instead of here. But again, just to give you a general sense for who they are and what they do and what we're here on their behalf. The history of the Nurse Licensure Compact, and really by way of saying, it's been around for a long time. Amongst certainly health professions compacts, I'm going to guess amongst compacts generally, it really was first thought up around 1997. It's in fact been around long enough that when we say Nurse Licensure Compact, we are actually referring to what is now known as the Enhanced Nurse Licensing Compact, because in 2015 they had enough experience with the existing compact under the 25 states that had to that point passed it, that they made some improvements. And now what they label the Enhanced Nurse Licensure Compact, which was implemented in 2018. Largely what they did, and it's what we would as a state be adopting, is to make more uniform the provisions in the compact regarding nurse licensing standards, and insert a requirement that in order to receive a multi-state license, anyone who applies for a multi-state license has to be subject to a national criminal background check. So that was one of the things that they added, again, to now have the enhanced NLC. And next slide, there are now 34 states that have passed the legislation to join the Nurse Licensure Compact. Most recently, actually it was in the past few weeks, I believe, it was New Jersey. But New Jersey and Indiana passed it this year. You can see the states within the region include Idaho, Montana, Utah, Wyoming, Arizona, Colorado, New Mexico. No state in the 2 decades that it has been around have withdrawn, although Rhode Island did choose not to transition to the enhanced. So they are not a member of the enhanced Nurse Licensure Compact, although the other states that were part of the NLC did transition to the enhanced. There are probably 5 or 6 other states at this point where legislation is pending in different states of readiness. So, we are approaching 40 states that either have passed or are giving serious consideration to passing it. Next slide. And this obviously would not be the first, nor would it likely be the last health professions compact that our state had passed. As Representative Riccelli mentioned, we have passed the medical licensure compact in 2017. We have passed the physical therapy licensure compact also in 2017. And actually both of those were passed in our state even prior to their initial implementation nationwide. So we have a lot more experience with the Nurse Compact than we actually had with those two. In terms of its provisions, the NLC is most closely resembles the physical therapy licensure compact in terms of how it operates. In fact, if you looked at the two side by side, my speculation is that that the PT folks at least had seen the Nurse Licensure Compact before they put there together, because there's some similar language. Again, I say it won't be the last. In 2019, there was legislation that passed that directed DOH to explore options for adopting interstate compacts with regard to behavioral health professions. Now, that particular language was vetoed by the governor because it lacked funding that went along with it for DOH to actually do the job. But even in the veto message, he noted that he supported the concept, probably all by way of saying this is not the last that the legislature will consider interstate compacts for health professions beyond what we have done already and beyond the Nurse Licensure Compact. Senator Riccelli, next slide. Senator Riccelli, or Representative Riccelli, talked briefly about the benefits of the NLC. I will use this slide rather than simply repeat what he said to refer you to one other piece of paper that we had provided you that lists with at least a little bit more detail, which is from the National Council. It's the one that just says NLC on top, and it talks, like I say, in a little bit more detail about the benefits of the NLC, and encourage you to take a look at that as your time allows. And then finally, with regard to the background, what I listed here is just some of the supporters. And what I did is took those supporters of the Nurse Licensure Compact of relevance to this collaborative. In fact, I've yet to find a group or organization with an interest in telehealth where they have taken a position on the compact that they have other than supported it. And then use it to, the last one there listed is the National Consortium of Telehealth Resource Centers, which also attaches back to another piece of paper that you've been provided. They have a document, and you now have it, where they list their telehealth policy issues and identify some of the things they see as obstacles to expanding telehealth. And one of the things they explicitly identify as helping remove an obstacle to telehealth is the nurse licensing compact. And like I say, my sense is it's very similar language to that which is used by the other organizations there. So I will now turn it over to Alexa, and she's going to briefly go through, or maybe I'll stop there and see if there's any questions. And if not, Alexa's going to briefly go through actually what's in the bill that will be before the legislature in session.
Jonathan, I had a question. I know for the physician compact, you need to get fingerprinted. And that has, practically speaking, has been a major barrier. Just getting very busy clinicians to go down to the Washington State Patrol to get fingerprinted. I've also had a little bit of backlash from physicians, kind of feeling like that feels very invasive of their privacy, and they're concerned about how that information is being used. Have other states or other organizations?
You know, and I think it's one of the reasons, I get back to what Representative Riccelli said, that notion that it remains optional. Yeah. Now, in this state, at least for the nurses, if you are an out-of-state applicant for an in-state, single-state license, you already are required to do the federal background checks. So it would not be the first time in this state that nurse licensure applicants are required to provide that information. Now, I believe the language in the bill, what it says is fingerprints or other biometric data. I assume that they use fingerprints, but at some point that I gather it leaves the door open for other methods that would then be allow for the state to get information from the National Criminal Background Check. The other thing, Alexa will talk about briefly, one of the additions made in the bill this year versus last year is to make very explicit that the bill cannot be construed to authorize what is known as ratback, which actually is almost like a 24/7, 365 criminal background check with the willingness to provide the state with ongoing information. This is a point-in-time background check. And again, there was some concern that it could be interpreted to allow that more comprehensive, some would say invasive, criminal background check, and there's language in the bill this year that makes clear it can't be used for that.
Micah on the line can comment on fingerprint developments if needed.
Yeah, Micah from the Medical Quality Commission. Micah? Just unmute yourself.
Can everyone hear me?
Yeah, go ahead.
All right, sure. So the couple of developments that have actually happened in the last couple of weeks. The first thing is the Department of Health is the one that processes all of the FBI background checks for health professions. They, due to FBI audit, are the exclusive processors of that, and they effectively take that information, scan it to the State Patrol, and wait for the State Patrol to run it. Historically, you are correct, Dr. Scott, that has been a time barrier in excess of 30 days. In the last few weeks, they've actually gotten that down to about a 5-day processing time for them, and then an additional 2 to 3 days at the State Patrol. The other thing that has happened is that they have implemented what's called a live scan vendor. So historically, if you were in the state, you would have to go to a law enforcement office and get fingerprinted. Now they have now implemented a vendor, a private vendor, that similar to when you go get TSA pre-check or something like that, where they just scan your fingerprints directly to State Patrol and they bypass the Department of Health process. We anticipate that that is going to speed up the process greatly and also offer more options for those who are needing to get fingerprinted either through the traditional process or through the compact process. And the gentleman that was speaking for me is correct. It's people that are coming from out of state are automatically getting fingerprinted simply because when we do the standard Washington State Patrol check, we obviously don't know anything outside of the borders of Washington through that check.
Thank you, Micah. I think that's reassuring and also great to hear that process is getting streamlined.
I have a question for Jonathan. One of our barriers to using the physician medical licensure compact is the $700 application origination fee, and then the fee that you still have to pay for each state that the physician applies to. What is the cost to a nurse to use this?
So my understanding is that would need be determined by the Nursing Quality Assurance Commission. Typical of other states, and I think is what we would see in this state, which is there will be the single state application license that is, governed. And in fact, I think all of the boards right now are going through a fee increase process. And then there would be the ability for an additional fee to receive the multi-state license. So I want to be cautious. I don't know necessarily it's right to characterize an add-on, but in my mind, that's sort of what it would be, which is you could get the single state license. And again, the cost of that, I mean, everything remains bound by the notion in our state law that says that the disciplinary system and the licensing system, in essence, all have to be self-supporting. And so I've not seen from the Nursing Quality Assurance Commission what they would anticipate would be a fee attached to this, but it would be the single state license plus an addendum to receive the multi-state license. Like I say, again, anticipating that they would model it after what we've seen in other states.
So if
That's a lot of money.
if I'm hearing correctly, it's still unknown whether or not there will be an additional fee to apply to other states and what that fee may be. And it's still unknown if the nurses would have to pay the licensing fee in those other states as well.
Sarah, can I address this? Yeah, just a little bit, and Jonathan can follow.
Tammy, can you introduce yourself?
Yeah, sure. Tammy Pro, Department of Defense. So I've worked on this in several states, and just for clarity, this is different than the physician compact in that you do not have to purchase your license in every separate state. Once you have your compact license, it is then good in Washington being the 35th state, let's assume, in all of the other 34 states, unlike the physician compact where you then have to have a license in each of the other states. So once you have your Washington state compact license, it's then valid in all those other 34 states. So a Washington compact license, one state, one fee, that's it, you're done. Some states have actually had their state license fee be the same cost as their single state license, because they said, okay, the cost of processing those two licenses is essentially the same for us. And they were able to keep those fees identical and not have to change those. So we've seen, and they wanted to keep the barriers the same for receiving those licenses. So there's been states that have had very little change in the cost of that, because states want to keep their license costs as low as possible and as even with the cost of managing their programs as possible. So do not expect it to have those same costs as what we see in the physician compact licenses, Sarah.
Thank you.
And the way they it's the notion that the receiving your interstate license or your multi-state license in your home state gives you the privilege of practicing without anything additional in the remaining other compact states. So there is, as Tammy said, there is no interaction in terms of the licensing process for you as an individual with that other state. And the fee that is charged here will be left up to the Nursing Quality Assurance Commission to determine. Again, bound by the state law that says they've got to cover their costs.
That's reassuring. I think Representative Riccelli also wanted to chime in.
Yeah, I think it's been brought up, but again, it's optional in nature. This is not cutting edge stuff. We're, be the 34th state. We like to lead on telehealth particularly. So, my interest is really working with folks to hammer this out. I do appreciate, I know there were some concerns with the wrap back. I appreciate the work that's gone on outside of session, outside the meetings to drill down this. But again, if people have concerns about privacy and these other things, then don't go get the license.
So Jonathan, we have about 5 more minutes. I wanted to wrap up, and I apologize, Alexa. Anything you want to kind of bring out? Because I also want to make sure that our colleagues from the Washington State Nursing Association have a chance to chime in as well. maybe some of your colleagues from DOT and JBLM want to say something. Alexa, anything you wanted to?
Well, I'm trying to think of what I was going to go through the provisions of the bill. I think we probably all understand the basics of how interstate compacts work in terms of allowing a state with a multi-state license, nurse with a multi-state license to practice in any party state. And people have already brought up the single state license would still be an option. I'll point out a couple of things. The licensing standards that apply are the nurse's home state's qualifications. So that's the state where the nurse resides. There are some kind of standard qualifications listed in the bill around education, exam results. The practice standards that apply are where the patient's located. So that's called the remote state. So if you have a nurse in Idaho practicing under the multi-state privilege and serving a patient in Washington, it would be Washington's practice standards that would apply. And then the changes compared to last year's bill this year, first it clarifies that the Interstate Commission that administers the compact can't actually alter those requirements for obtaining a license or renewing a license through its rules and bylaws. So that's a sovereignty issue, and that's clarified in the bill this year. And then on the background checks, we already talked about prohibiting rat back, but the other change related to background checks is clarifying confidentiality of background check results. So when the Nursing Commission gets the results, they cannot share them beyond.
That's really helpful. Tammy or any of your colleagues from JBLM want to add anything more?
I will just, I think that we'll just ask on the phone if Colonel McCoy or Major Matters or Colonel Paul have any questions. Okay.
So this is Colonel Paul. I don't have any questions.
Okay.
Thank you. And I know we have someone from the Washington State Nursing Association present. I want to give them an opportunity to chime in here. Do you have someone? Okay, here we go.
Good morning. I'm Melissa Johnson. I'm representing the Washington State Nurses Association. And I just want to appreciate Representative Riccelli's work, Jonathan, Alexa, Patty. We did raise concerns last session. Some of them have been addressed by the amendments, the proposed amendments, so we appreciate that. The rat back was a large concern with a lot of our members. And we have had meetings with the Nursing Commission this summer in order to try to address some of the other concerns that we have raised so that we can go into session hopefully on the same page. So I want to just tell you what those concerns are. Where the patient resides, the scope of practice in that state, we want to make sure that the nurse understands and knows what that scope of practice is. Because while we're only talking about the RN license, there are states that have different scopes of practice about what RNs do. So knowing if you're a Washington nurse and you're practicing in Alabama may have a widely different scope of practice. And making sure that there are tools for our nurses to understand that, because this is an added liability. We want to make sure that the nurse understands that they need to know what that scope of practice is, where the patient is. They may not actually know where the patient is in some circumstances. So that's a concern. So we brought that with the Nursing Commission, hoping to work with the national state boards to give tools other than a link to a website with a list of statutes. If we can do kind of a landscape scan of here are the top 10 differences in the scope of practice. So that's one issue. The other issue, and I think this is unlike the physical therapy compact, because I did work on behalf of the PT Association of Washington to get that passed a couple of years ago. In that one, the person with the compact privilege has to notify the state, the other compact state that they're practicing in, so that the licensing board in the remote state knows that PT is practicing, and that is not part of the nursing compact. So our Nursing Commission, if we join, become the 35th state, there will be 34 other states of lots of those nurses that could be practicing in Washington, and our Nursing Commission won't know while they're practicing. They will know if there's a disciplinary action that's brought in one of the remote states, but they won't, that's kind of after the fact. They won't know who. So that's just a difference that I'll note from some of the other compacts in other professions. And then just finally, we appreciate the wrap back. That was a concern. We do understand and appreciate that the discipline data, that's one of the good reasons from our perspective of why a compact is helpful, because we know from our Nursing Commission that they get kind of delayed information about what's happening with nurses that have a Washington license that may have another state license currently. So we appreciate that. We do know that Oregon is not a compact member, nor is California. And from our information from those states is they don't plan to anytime soon. So while it's great for the Spokane, that Washington-Idaho border, it doesn't really help for Washington, Oregon. And then we do know that there are a couple of states that have tried to amend the compact and have been unsuccessful, and then have not, and have been kind of rejected from the compact. So we are still trying to gather information from those states about why that is. But we've had very robust conversations with the Nursing Commission this summer to try and get it, to kind of make sure that all the concerns are on the table. And we will continue to work with them and with Jonathan and Patty and Alexa.
That's great. So maybe by ways of wrapping this up, I want to bring it back to Representative Riccelli. Representative Riccelli, would it be possible for us to see a draft version of this bill next time? And maybe we could discuss it. And I'm just wondering, would it be helpful for us to support this bill? Obviously taking it into account some very valid concerns by
Dr. Scott, we had forwarded the draft.
Oh, okay.
So you have the draft of the bill.
Okay. Okay. Good. So maybe as an action item, we'll ask people to review that in more depth now that we have a little bit more context, and we can actually maybe vote next time to see if this is something that the collaborative would be in support of. Does that sound like a fair action item?
Excellent.
Okay, great. Good. Thank you very much. Very interesting conversation. I appreciate everyone chiming in on that. So we're going to move on to the next agenda item. And I'm going to ask Ray Hanley to introduce his colleagues, Mary and Emily. And Mary, maybe I can have you sit next to me because the microphone is a little better, and I can be your slide advisor.
Emily and I have been sort of chatting back there in the corner, and we're so grateful to be here. But to get you guys back on schedule, we'd be more than willing to come to a future meeting, and you guys can sit the rest of your.
You know what? You drove all the way from Olympia. We want to hear from you, okay?
Do you want to sit?
Well, if I can introduce them, John.
Oh, we got two chairs here.
While they're getting seated to try to keep us moving. My name is Ray Hanley. I'm from Labor and Industries, and I have, we're lucky today to have two people to talk about telehealth policy at Labor and Industries. Emily Stinson is the person who is involved with creating policy, which is a deliberative evidence-based process in Labor and Industries. And Mary Kemp is the person who you can sort of think of as the person who makes policy work, because she is our provider outreach and support individual. So today we're going to talk a little bit about policy. We'll also talk, to give some of the folks in the room a little bit better understanding of Labor and Industries, a little thumbnail sketch, how we're different, and some of the obstacles, as well as our policy. So with no further ado, I'll turn it over to my two colleagues.
Thanks, Ray.
Thanks.
And one last thing. We have two things to march us forward. One is a fact sheet, and I'll pass these down. It's a little fact sheet of how telepolicy works at Labor and Industries. And the second is our PowerPoint. If anybody wants a copy of the PowerPoint to take that,
We already shared that.
But we're going to share that on right now.
So as I mentioned, we're really grateful to be here. We have been following the work of the collaborative from your first meeting. And I think we may have only missed one or two as an agency. And so we were delighted that the collaborative came into being to address some of the issues. I personally have been watching telehealth issues since 2009 and and the infrastructure just hasn't been there. And there's lots of parts of the infrastructure that haven't been there. So you all are starting to address some of those things. And so I think the next few years are going to be pretty exciting. We've been interested in it from an access to care perspective. My personal interest has been around access to mental health. So moving on just a little bit. Okay, so what we're going to cover today is our safety tip and the questions that Nicole sent us that you had for us. So we're going to try to address those. And that's what we're going to cover today. And if you have any questions, we're here for that too. So at L&I, we're all about safety. And we're the workers' comp insurer in the state. And the best injury is the one that doesn't happen. So we start every single meeting with a safety tip, and we recommend that you all do too. And so we've given you a couple links where you can go and find different kinds of safety tips if you're just, can't think of something off the top of your head. That's all we'll say about that. So just in general, and this one I did.
Sorry, I'll let you drive.
Oh, okay, sorry. So we are kind of a niche payer. Many of you have probably never even worked with us, or if you have, it's a very small segment of your patient load, and many of your providers may have never even seen an injured worker. But we play an important role within our communities and our society. We are a state agency, and we do both the workers' comp insurance, and we also have what we call up here the OSHA, but we're a state-run OSHA. So we have the safety side of the house, the safety prevention, or the injury prevention side, and if that safety net breaks, somebody gets hurt, then we provide the insurance to take care of that worker and help them get back to work. Some of the characteristics of Washington's system, that some of these are very unique to our state. Premiums are paid by both employers and workers. We consider both owners of the system. We can only, unlike general health insurance, we can only pay for the treatment of conditions that have been caused by the work injury or illness. So that sometimes creates some, like, well, is it related or not? And if so, how? Unlike other general healthcare payers, we have some additional benefits that we're responsible for. If somebody can't work, we'll pay wage replacement benefits if they can't work because of their injury. We also provide vocational assistance and help to go back to work. Those are two sets of benefits that are very different than general health insurance. And our goal is to return somebody, to help a worker, which we almost never use the word patient, because we're working with workers, and our goal is to help those workers return as close as possible to their pre-injury condition, and the primary part of that is that they were working. So that's our main goal. So what are we talking about? These numbers are from the state fund side of the house. So we are an exclusive state fund here in Washington, and we cover almost all of the employers and workers. And then there's a self-insurance section where some of the large employers can self-insure, take care of their own workers and their own benefits, but they have to follow the same policies and rules that all of the other employers in the state have to follow. And some of those are the policies that Emily's going to talk about. So just on the state fund side, you can see that it's the last fiscal year, about 180,000 employers. Those are the employers who buy their insurance from us, and almost 3 million workers. And over $2 billion in premium were collected. Last year we had 111,000 claims that were filed with us. Those are new claims. What we call a claim is a case. It's not a bill. I need to always remember that. A claim for us is a case. And we awarded almost 900 pensions last year. Now those pensions are not part of that 111,000. Those pensions are injuries that likely occurred several years ago. The average worker is about 38, and most of them are men. Like I said, on the self-insured side, their numbers, they cover the other third of the workers, but it's only about 360 employers. So these are the really big employers.
All right. So when Labor and Industries makes policy, we have specific goals in mind. Chief among them are that we make transparent policies that are easily understandable, usable by the providers, and that are evidence-based when it comes to coverage. We also have a WAC that governs the treatment that patients can receive, and it deems that the treatment must be proper and necessary. And what that means for us is that treatment is curative and rehabilitative, so not palliative. It's moving the patient's health forward towards an outcome rather than keeping them where they are. It must not be experimental or investigational. And it must be not done primarily for the convenience of the patient or the doctor. As far as coverage decisions go, we're looking at the evidentiary basis for treatment, which does include effectiveness as one of the primary drivers. We do consider what Medicare and other payers allow also. We're looking at the standard of care across the industry. And we're also looking to compare new therapies to existing therapies for the same conditions. So we passed out a telehealth fact sheet, which there's no way you could have digested by now. But that's okay. I'm going to give you the highlights.
We think you all can read it.
Yeah.
So we're not going to go through point by point.
Yeah, absolutely. This is intended mostly as an artifact for you if you have questions or interest in our system. This represents our current policy, which is based on Medicare fee-for-service. It allows treatment. It allows for some types of treatment. It requires referral from what we call the attending provider, which is a PCP. It requires a clinic setting for an origination site. Home is not currently allowed. We've always had pay parity for services delivered. Currently, we don't allow store and forward, and telehealth as a delivery method does not require prior authorization in our system.
Special codes and same.
So we got some questions from y'all, and this is our attempt to kind of tell you where we're at and what questions we have. And, right now we're looking to learn more and hopefully in the future expand our telehealth policy, but we want to make sure we're going in the right direction and that we get to do it once and the right way. So with that, the questions that we have right now that are outstanding that we hope we can get some guidance or input on, or even just discussion, are what's the evidentiary basis for use of home as an origination site? How does this work with physical exams? And is it more or less effective for specific treatments or specific conditions? We also would like to know, what we're trying to solve really is an infrastructure problem with a technological solution. We don't have locations for care where the patients are. So we're relying on technology to a certain extent to help ease that. And that's a great solution, but the technology hasn't totally caught up yet. High-speed internet hasn't gotten everywhere yet. So we're looking to understand how we can ensure access for all where high-speed internet hasn't gotten. So it's just an outstanding head scratcher. And the other question that we have for L&I specifically, and I don't know how much it really affects other payers, but for us, the question comes up, who purchases the equipment, who owns it, and who maintains it? So we're looking at that. We're trying to make sure, like I said, we make decisions that are defensible, understandable, and that balance the, you know, the needs of patients against the costs to the fund where possible. I think you're next.
So kind of going on a little bit more, you guys were talking a little bit earlier about some of this around the proxy issue, and that's something we have questions about too, and we're not sure how to address them yet.
Proxy credentialing?
Yeah, what qualifications do they need? How should they be paid? When is a proxy necessary? When can you do it without a proxy?
The term that we would use is a telepresenter. Right?
Sure. Okay.
Having a nurse there.
Somebody to facilitate the exam.
Yes.
Right.
Yes. Yep. Yeah. So we've been calling it a proxy. So we may need to change our language.
Proxy for us is accreditation.
Oh,
okay. Yeah. So
got it. Got it. Thank you.
Telepresenter.
Telepresenter. We'll write that one.
We'll write that one down.
So we look at that as that's somebody who's actually helping to deliver the care, and they should be reimbursed, but we don't know how to do it. We don't know what creds they need. We don't know when they're necessary and when they're not. So we could really use some help around figuring that kind of stuff out.
And if I just may add, for us, it's really critical to know the answer to this question, because the nuance of our system is that every medical exam, every medical service is also has a legal layer, right? Because what's keeping the claim open is the provider, the medical providers attesting to it needing to be open and needing to care to continue. And, you know, this can have reimbursement issues for the worker, for the patient, because their time loss, their payment for their wage replacement is based on these medical services. So this question for us is a big one in terms of what might be a best practice.
Right. And then, as we said at the very beginning, since our system is funded by both workers and employers, all of these costs then affect the premiums for all of those people or entities. And so we're lucky that for the most part, we really get to just think about what's in the best interest of the worker. And as a matter of fact, the statute says, when in doubt, err on the side of the worker. But these are just some questions that we have, and we're hoping that you guys can maybe put them on a list somewhere and say, yeah, we want to tackle that.
Mary, we've worked with you before with occupational medicine, and we do a lot of the direct-to-patient homes, and I'm sure some of the other folks here do too. And I think we can help walk you through what's typical in the industry.
Great.
Reimbursement modalities, like we refer to them as bring your own device a lot of times, you know, the patient's on mobile device. So we'd be happy to take that.
Oh, I'd love that, Denny. I would love that. We'll set something up.
Yes, absolutely.
And maybe we can also speak to home as originating site, because that was one of the first actions of the collaborative.
And we saw that.
Yeah. So, I mean, I worked in occupational medicine. And I know a lot of these are musculoskeletal, sometimes lacerations. And so you really do need to have a good first exam. So my suggestion is that, you know, the ideal use case is often in the follow-up visits, because that first exam is so crucial, and that can be potentially cost saving. My other understanding is that access is a big issue for L&I, that not everyone will take it, and that sometimes people can be waiting weeks, even months to get in, and that's time where they're not getting back to work, as you said, the time where their injury is actually getting worse. And I don't, that's tricky if you're so dependent on the physical exam. I don't really have a ready solution on that.
I think if we start talking about it, and maybe we can start teasing some things out, I would really love that.
And we also can give you an idea on the federal landscape where this is going with respect to the home. So example, mental health and substance abuse is going to be covered in the home by CMS. And we have a lot of federal legislation in the works right now that's going to open that door a little bit wider. And we can also help you talk about how CMS covers critical access hospital originating sites for patients.
Great, awesome. So we did watch, we watched very closely what you all were doing and your recommendations around home. And for, because of the nature, it's right there.
I'm just gonna flipping back and forth to see what your questions were.
Okay, there it is. So because our system is also a legal system. It's not just a healthcare system. And because of that, sometimes there is friction between an employer and the worker in a workers' comp setting. Sometimes their goals don't align. And as you all know, the first rule of telehealth is that both the provider and the patient have to be comfortable with the setting and with how it's performed and just the whole process. And so we have some questions around that part of your recommendation for workers' comp, around the employer being a possible home site. But it's been exciting to see the work you guys have been doing and the progress you're making. And I'd say particularly in the last 6 to 12 months, like, you guys have really just kind of pumped it up, and it's been fun to watch. And as I said, we've been watching on the sidelines since the beginning.
So it sounds like Danny is going to provide some resources offline. Great. The other resource that I wanted to point you to is the American Telemedicine Association. They have guidelines for specialties, and they also have a bibliography of the evidence base for a lot of different conditions. It's last time I checked, it was up to like 200. This often's been studied. The other resource is the Northwest Regional Telehealth Resource Center.
We use that.
Their meeting is next week in Anchorage. If you want to go up there.
Darn it.
They have a website. And they're open.
They don't let us travel out of state too much.
And then, I think your last question about working with the critical access hospitals to host telehealth visits is a really good one. And I don't know if that's through APAC or some of these other, the Rural Primary Care Association. But I personally, as a provider, would be very interested in working with them for LMI.
And if we have a moment, I'll just give you a little snippet. We have a telemovement program. So just give you an idea of what it looks like with the telepresenter on the patient side. So we go up to Port Angeles into one of their small clinics that are associated with the hospital. Physicians are downtown Seattle. Patients are in Squim, and they have a trained telepresenter nurse who does neuro assessments under the guidance of the physician. And so that's your proxy.
Right,
and that is
right.
someone who's trained specifically
That's awesome.
Yeah, we have inpatient nurses that do a whole head to toe neuro under the direction of the physician. But that hands-on piece, we also have Bluetooth stethoscopes. So there's a variety of tools that can be used to give a full assessment under the direction of the physician. And I think your point, Dr. Scott, specifically to that initial appointment, where you have a lot of physicians want to have hands-on. They want to feel, they want to touch, they want to look at all that. And we do that for this movement disorders program as well, because we're looking at rigidity and different assessments that really need to have your hands on. Right. And then the follow-up appointments then are assessed with the assistance of the telepresenter. I think in your case, I think that's a good example of what it might look like.
Yes, absolutely.
Yes.
Thank you. Thanks.
I having tonsillitis exams, sometimes there's a standardized evaluation form. It's a very detailed musculoskeletal exam, is my recollection. That
are you talking about the activity prescription form?
It's a baseline eval, but then also sometimes when people were coming in, if they were injured, I would be handed a form, and I had. So if you're not clued into all of that, sometimes the claim will get denied. So I think there's a lot of opportunities.
That's where my team comes in. You can call us for help. We'll help you through all that. And the only other thing that, kind of based on what you just said, this was my plea in the first collaborative meeting, is there are no registries that I'm aware of that list possible telehealth sites and telehealth providers.
Providers, you mean clinical specialties?
Yeah, practitioners who actually deliver care via telemedicine.
Okay.
So then
he can help you with that, because CMS is probably the best benchmark for that type of thing, although we go a little bit more broadly with Washington State.
Right, because we have, I work with providers who are not part of a large healthcare organization. They would love to possibly do telehealth visits, but telemedicine visits, but because they're not part of a large healthcare organization, it's hard for them to tap in.
So if you look at our Washington State original parity bill, it says if the service can be billed in person, it needs to be reimbursed telematically. So if you're probably a registered clinical provider of some sort, and you can bill for that face-to-face, likewise you can bill for it telematically.
Oh yeah, no problem. That's not the problem. It's finding an origination site to use.
Where the patient would be.
Where the patient would be. So I don't know where all of her sites are that I can point patients and their attending providers to.
Oh, I see. You're looking for locations for patients.
Yes.
Yeah.
Yes.
Yes.
You have to dig through each
And
website.
our understanding is that not all services are appropriate for living in
or available
in a home setting.
Well, it's billable too.
Right. So that's my other plea, and has been from the get-go, is help us identify where these sites are available so we can connect people.
Great, well, thank you very much. I think we're going to postpone the next agenda item, which was the subcommittee updates. We'll maybe put that first next time. So I wanted to turn it over to Nicole very briefly. So Nicole has been doing a little bit of investigating about revamping the website. I think one of the concerns is that the information on the website is not easily discoverable. It kind of is buried in the WISHA website. And so Nicole's been doing a little bit of research on that and has a little bit of expertise in building a website. So I don't know if you want to give some mock-ups or just talk a little bit about.
So I, for some reason, couldn't get to the site, which is ironic that I created an app on. Can you do me a favor? Open up. I am on Zoom. So I'm going to share my screen. So I'm going to share my screen really quick. So I think that there, just in terms of broader communication with the collaborative, I think we've been doing okay, but I think it could be better. So I've drafted. So I have two propositions for the collaborative. The first is I'd like to get some feedback on how you guys would feel about receiving sort of like a monthly collaborative update. So on the one hand, right now our communication up to this point has basically been just some emails reminding you when the next meeting is, and then some sort of offline communication of, hey, you have a presentation coming up, where are you on that? But I have started to get emails from people about upcoming conferences, updates on resources, developments in your own systems, and I think that part of the benefit of being in the collaborative is for us to share resources with each other. So how would you feel about having a newsletter in your email, which I know your emails are already crazy, but basically just once a month having a quick summary of, hey, these are the action items that we talked about, here's the deadlines, here's some new resources that have come up that people have sent to me and that I can share out to everyone, here's when the next meeting is. And also, just now that we have the subcommittees up and running, also have it be a place where I can easily access everyone on the subcommittees, remind them what their tasks are, and also just keep it transparent what all the subcommittees are up to. This is not the final layout. This is very much a mock-up. MailChimp was giving me a really hard time this week, so I just threw this together in Word. But how can I get some reactions to the idea of a newsletter?
Definitely.
Yes.
More front-facing.
More front-facing?
And
okay.
would you be the keeper of the
I would be the keeper of the keys, yes.
I think we need a commitment from folks to feed the engine for this thing, but there's a lot we could put on there. Federal landscape, what's happening, lots of things.
Exactly, yeah, policy updates.
I think it'd be fabulous.
Okay.
Yeah, definitely.
All right, so that's really good to know. In terms of cadence, does once a month sound appropriate, or would you prefer less, more? Do you think it's okay? Okay. Okay. I'm also toying with the idea of once we get this up and running, I could create like a Google form. So if you do have something that you want to send me, you could just fill it out. It could be in the newsletter, like, oh, I've got this thing I want Nicole to know about, and send out to everyone. So just try to make it as easy as possible.
So this is public facing?
Well, so right now, the way our mailing list works, I have two parallel mailing lists. One is for the collaborative members and their assistants, and anybody directly responsible, and then the other is a public list. In my head, it was for the collaborative list, but I hadn't thought about that far. Should we include the public as well?
I'm thinking of it from an awareness perspective. For example, if occasionally somebody has a very patient's dog that needs telehealth, we're trying to get providers and patients more aware. That might be one way to do it. Be able to push it out to somebody.
Okay. I'm wondering too, maybe quarterly on that basis.
That you're right.
You know, so
Yeah.
monthly for an information for the collaborative, but maybe quarterly something that's more outward facing.
Okay, I like that
Thought,
idea
just
a
a
lot.
thought
Yeah.
of that.
That's a great idea.
Yeah, absolutely. Any other thoughts on the newsletter? Okay. Is it not working for you either?
We're trying to pull up a mock-up of the website.
So I know that right now the website is hosted through Wisha, which I can pull that up at least. And it's wonderful. They're doing a great job. This isn't a reflection on them at all. But it's a little baried.
So unless you did a Google search, you wouldn't come across it. And it does come up if you do a Google search. But
right, and it comes up, Google search. Yeah, you have to do a very specific Google search. You have to know, what to Google, which is half the battle, honestly. So when you Google Washington State Telehealth Collaborative, it does come up, and it does come up as its own title. It's not, Wisha first, which I think is really, really helpful. But it is a bit buried, so you can sort of see this is the location of the site, this line here. So you have to go to the homepage, then Government Affairs, then Issues, then Telehealth, and then you're in Washington State Telehealth Collaborative. So for someone that's just trying to learn more about what the collaborative does, this isn't the most intuitive location for our site. I also know that with the state funding, I believe that funding is not supposed to go towards, hosting costs and
which has been given this to us for free.
Right, which is amazing. However, I know that there are services out there that will host for free. Wix is one of them. It's a little alarming that we can't access them right now, so I'm wondering maybe they're not the best ones to use. They're really pretty templates. So I think that's actually a firewall issue because we're on a public Wi-Fi source right now.
Block you at
You're supposed to be transparent. But so anyway, so I started to mess around. There are some templates that we could use that are actually quite nice. They look professional. I wish I could show you, but they. Just in terms of the basic purpose of the website, what purpose do you think the website is serving? What purpose do you think the website should serve? And then I can try to incorporate that into a mock-up that I would be able to present at the next meeting.
If the originally was a clearinghouse, it's meant to be, we have an FAQ document for patients and providers.
We've got two here.
The minutes, we have the summary document that's presented to the legislature.
And we do have a good list of resources. So I could see, at the very least, I could basically recreate what we already have, but have it be its own page. But then that gets into issues of how do we make sure that it's still Googleable. and easy to find. And how important is it that we have our own standalone web presence in comparison to being nested under the Wisha site? A lot of
much easier to find and more public facing. It's going to get us better, I think.
Yeah.
Yeah.
I just wondered if you considered kind of doing a little survey of people who aren't at the table and providers who aren't at the table of what, if they were going to, if they were looking for telehealth, right info, what would they Google? What would they look for?
Yeah.
What sites would they think, what sites would they intuitively think to go to look for it?
I wonder if we could get a link, our link, on other websites like this one, yours, or something.
You know, I was thinking about that. Probably not this moment because we're redesigning our whole website and it's going into a freeze in September.
Hypothetical.
But by the end of the year, it might be possible. We can certainly, we can ask. We could ask. I'm not sure that our website is the one that people would intuitively think to go to for this, because we're not a high user. It's a niche. It's a niche group of patients, but
we can definitely ask.
We can definitely ask.
We've got state organizations, we got health systems, payers, whatever.
Yeah, the first thing that came to my mind is Northwest
PRC.
Yeah. I will say that, so right now my contact information is posted as the program contact, and I have been sort of fielding some wide range of telehealth inquiries, everything from what medication should I give my telehealth patient to, what are my specific